Okay. We're gonna have at least 3 people I know aren't gonna be here today. And then maybe some people are feeling like I am, like, wow, it's hard to get restarted after 9 days off. So I am recording this morning and it will be up on Canvas later today. But I wanted to show you guys something on Canvas that is going to be helpful for the exam, for prepping for the exam, which is going to be on Wednesday. And what it is a figure. So I had mentioned to you all that the first part of the exam, you're going to have a diagram of male and female reproductive anatomy, and it's got letters on it. And then there'll be a big list of descriptions of what the different things do. And the diagram that I used on this is actually it's not from OpenStax. It's actually this. So I went ahead and put this up on Canvas so that you can look at it and kind of familiarize yourself with it, since it's a little bit different from the OpenStax diagram. So it'll be one view of male anatomy on the front page, and then there's a view for female anatomy on the back page. I've actually tried to print some, but something's going on with the printer today, and it's not even electrified. So. Yes.
Even though, oh, I already know the answer. So, for next class, all we have left to be in the very system. It's the final, and then it's test one.
Yes,
Nothing else.
that's it.
Nothing else.
As long as all the lab grades are in there, there shouldn't be anything else besides this exam 5 and then the final. Yeah. Yeah. So exam 5 will be on Wednesday. You'll get them back on Friday. We'll go over them a little bit. And then on Friday, I will describe how you do your final exam. And final exam, you have a week to work on it from this Friday at 5 until next Friday at 5. And it's basically like a take home, or it's a online Canvas exam. You won't come here in person to do your final. It's just online. So we'll go over how that's going to work on Friday. So we have a decent amount of stuff to finish up in this slide set, which is basically about pregnancy and things that happen during pregnancy. And when we had stopped, we had been looking at this diagram of blood volume increase and how a pregnant woman's blood volume will increase really dramatically by the end of pregnancy. And this has some very big implications, let's say. And I don't remember how many implications we talked about, but the biggest implication that this has for the mom is it will increase her blood pressure. So almost all women will experience an increase in blood pressure during pregnancy because they've got more blood volume, both for themselves and for the fetus going through the placenta. And just by having more volume, it will raise their blood pressure. So it's normal to have some increase in blood pressure, but you want to avoid getting it too high. Want to avoid having the blood pressure be too high. Because if the mother's blood pressure gets too high, that's going to be dangerous for both her and the fetus. And monitoring blood pressure is really important during pregnancy so that we can determine if a mother is experiencing this condition called preeclampsia, which is what this slide is about. So preeclampsia is one of the most dangerous conditions to have during pregnancy, and we don't really understand why it happens, even though it happens to a significant number of women during pregnancy. And if a woman is experiencing preeclampsia, she's going to have 3 symptoms of it that show early on. So the first one is blood pressure that is not just high, but more dangerously high. So high blood pressure. The second one is having protein in the urine, or proteinuria. I just remembered I want to stop screen sharing and put back on the normal camera. There we go. Okay, so high blood pressure, dangerously high blood pressure. The second aspect is proteinuria. And for proteinuria, the blood pressure is high enough to push or to filter proteins into the urine. Proteinuria is kind of a outcome of having really high blood pressure, because your blood pressure is so high that you're pushing proteins that shouldn't get filtered out. They are going into the urine, and you lose protein in the urine. That's proteinuria. And then the third aspect is just really significant full body edema, but especially in the lower legs. So for the edema, that's going to be most noticeable in lower limbs. And what this picture is showing is testing for that. So if you push your fingers into someone's foot or ankle and it makes dents, indentations, and the dents don't disappear right away, that's a sign of more serious edema. So together, the proteinuria, the high blood pressure, and the edema are the major indicators of preeclampsia. Once preeclampsia starts, we also don't have any good way to stop it. There is no very effective drug or very effective treatment for this. And what would normally happen is if the mom is experiencing this, she will have to immediately go to the hospital. They will try to bring her blood pressure down, usually does not work. And they will try to buy time until the fetus is mature enough to be born and have a chance. But it will not, you cannot maintain the mom having preeclampsia for very long. So it's a huge cause of preterm birth or babies being born too soon. Yeah.
But I thought when we got pregnant, her feet were.
Yeah, true. Did I tell you all my story about that? I will tell you a story about that. So what she said was, I thought when you get pregnant, your feet swell anyway. True. Yes, because you have higher blood volume and you'll get some edema from that. So when I was in Arkansas, I taught the same stuff as here, basically. And I had a student go into nursing school and she was learning about this. And I was pregnant a lot of the time in Arkansas. And she saw me one day and she said, "Oh, Dr. Ong, you need to let me check you. You need to let me check you because you look kind of swollen." And she just wanted to like check me on that. And I said, it's okay. I have cankles anyway. I did let her check me. I bounced back. I didn't have preeclampsia. I just have cankles plus the normal swelling.
So how do you know it's considered healthy? Or like
The amount of swelling?
Yeah.
Yeah, if you push, like you all could do this right now and nothing's gonna happen. If you push on the top of the foot or right above the ankle and the dent that you push in stays there, that's dangerous edema. It ought to bounce back. Yeah, it ought to bounce back. And it's not just in pregnancy that if it doesn't bounce back, that's the only time it's a problem, but that's how you check. Yeah. Oh yeah, one other thing about this. So one of the main things that women have checked when they go for prenatal care. You get on the scale, they take your blood pressure, you pee in a cup. And a lot of that is just checking for preeclampsia to try to identify it if it's happening early on, so that you can try to save the fetus and save the mom. So the other thing that will happen later in pregnancy when you go for checkups is measuring something called the fundal height. Measure that fundal height. So the uterus all the time, no matter if a woman is pregnant or not, it has this top curve called the fundus. Remember how the stomach had a fundus at the top curve? So fundus means kind of the topmost height of an organ. And the uterus has a fundus all the time, no matter what. But as pregnancy progresses and the fetus is growing, the uterus grows with it too. And the fundus, or the top of the uterus, will rise up during pregnancy. So this is showing you how many weeks, 12 weeks, 16, 36, and so on. And how high does the fundus get? So at some point in pregnancy, once the fundus rises out of the pubic area, past the pubic bone, the nurses or doctors will measure how many centimeters is it to the top of the fundus. So they started at pubic bone, stretch a measuring tape and measure the fundal height. And that's to track how well the fetus is growing. And this is like funny to me. 38 weeks, it gets up there so high. It's crowding all your internal organs. And then notice at 40, it goes back down. It goes back down because the fetus is going to settle head down in the pelvis. And then between weeks 38 and 40, if pregnancy persists that long, that's when you see women kind of start to walk funny and waddle. Because the fetus has settled head down and it's affecting how their pelvic joints work. So knowing how high the fundus is tells you, is the fetus growing properly as it should? That's something that happens during prenatal checkups. So most of the time, towards the end of pregnancy, as the fetus is getting bigger and more mature, they will end up being positioned with their head down. And this is a good thing. And it's thought that once they reach that position, they sort of have more room or it's more comfortable for them. So at some point they tend to stay that way. And being head down sort of gives them more room, and it also puts their head right next to the cervix, where they're eventually going to pass through when they're born. And having head pressure on the cervix helps the cervix get ready to open up for delivery. Notice also the direction that, I don't know if this is a boy or a girl, direction that they're facing. So head down. And it's best for their face to be toward mom's spine. That's the best position. And most fetuses will end up in that position before birth, but not all. That's going to be the safest position for vaginal birth. It's just like that. So being in that position and being head down, so this picture that you've got here, this is representing the head of the fetus, and here we've got cervix. And for the head to pass through the cervix needs to open up, or it needs to dilate. Cervix will need to dilate or open wider. And it will also need to do something called efface or effacement. Which is to get thinner in the depth. So before delivery is near, the cervix has this depth. And it is not open, it's not dilated. So this would be normal configuration. And toward the end of pregnancy, when the fetus's head is pushing and there are also hormonal changes that cause this, the cervix gets thinner in depth, which is effacement, and it also starts to open up or dilate. And how many centimeters is full dilation? 10, you already know that. Yes,
Yeah, I know it.
that's surprising. How do you know that?
I don't know.
But I didn't know that until I was pregnant. But this is a board, and those of you going into nursing will experience something like this, which is a practice board to see and also feel how does the cervix feel at different stages. Because this is monitored during labor manually by the nurse, putting on a glove and feeling your cervix, which didn't expect that. But you learn by feel, if you're a labor and delivery nurse, okay, that's the dilation, feel the thickness, feel the effacement, and 10 centimeters is full dilation. And gives the mom the most room to push the baby's head out. So 10 centimeters. People learn a lot of things these days from like Grey's Anatomy. Has a lot of good medical information. I never have watched it, but I know it's made a difference in.
Walking by my own, it's coming to an end. Everything great is doing.
It's still a show, it still has new episodes.
19 seasons.
It's embarrassing.
I get embarrassed. I remember sending,
I mean, it's not completely like medical training, but it's just people something.
I sat in a lab where Rebecca, I think,
Mm-hmm.
playing with a kidney one time, or playing with something. And I was like cutting it. I was like scalpel. And I was like, we got a bleeder, we got a bleeder. And she told me if I had a bleeder, there was something wrong with me.
Those shouldn't have blood in them. But
Suction.
this is kind of demonstrating, okay, how wide would the cervix be dilated and what food do you relate it to? 10 centimeters. I like that.
When you have a period, isn't it like 1 centimeter dilated?
I love that question. So when you have a period, it's really not dilated. But you know, that's liquid. It doesn't need a big space. So I don't think it dilates and contracts until pregnancy.
I heard that somewhere, I was just confirming.
I cannot confirm that. And I think it's not. I think it's not. Oh yeah, here's a slide about that. So this is kind of showing before dilation and effacement, full dilation and effacement. And the reason that this is monitored and that this is important is that the mom should not try to push until there's full cervical dilation. Otherwise, she'll just use a lot of energy needlessly. And this is also showing, so this would be the mom's belly button. If she was lying on her back, what is the correct positioning or what is the best positioning of the fetus? So head down, face toward her spine. And that's helpful for the way their neck needs to move during delivery. So during delivery, head comes first. And then whoever is doing the delivering, it's helpful if you slightly twist them. Then get the shoulders out, and after the shoulders are out, the worst is past. Or the best is past. I don't know.
Whenever they're, give the babies like head down, I heard that it's like good because they're less likely to aspirate, especially if like it's meconium stained fluid. I don't know, if that's a thing, or if that's just a coincidence.
There are a lot of reasons it's good for them to be head down. Partly because if their head comes through first, well, this kind of sounds harsh, but if their head is coming through first, they kind of have their mouth and their nose smushed and closed. And they are gonna be less likely to get fluid or meconium in their airways than they would be if their head was coming out last. If that makes sense. So having the head temporarily kind of smushed is gonna keep external substances out of their airway. Yeah. Something else that I have not previously mentioned is there is a fluid inside the uterus that the fetus is surrounded by, and that's called amniotic fluid. We should make a note of that. So there's a fluid called amniotic fluid that fills the uterus. And if you've seen in movies or heard a concept of the mom's water breaks, what that means is there's a membrane or a sac around the fetus that contains the amniotic fluid. And usually during early labor, that sac will rupture and break, and then the fluid comes out. It's amniotic fluid. After amniotic fluid, after the water breaks, let's say, there should not be too much time that passes that the fetus stays without that fluid. So once the water breaks, there's kind of a clock that starts, and you hope that delivery happens fairly soon after that and doesn't linger too long without that fluid.
If the baby is arranged differently, do you like have to do a C-section, or like what do they do with the baby's legs? Like how they
It
get,
totally depends on where you are and what your doctor's training is.
they're like completely flipped, like their head was at the top, like how do they get their legs up?
Yeah, let me get to the picture. There's a picture coming up that helps with that, and I have another story about that too. Not personal, but someone else's. This is just kind of not very much new information, but head should come first, then shoulders. After the shoulders, this baby's body is quite small and very squishy. So the shoulders are going to be the last difficult object to get out. And then afterward, the placenta will also have to be delivered, and it's about that size. There will be an umbilical cord that now is not attached to the mom anymore. And so that will eventually need to be cut. A lot of times they ask the dad if they want to do it. It's quite rubbery, quite strong. And then they'll have a little stump of umbilical cord left that will eventually just kind of dry up and fall off. And they'll have their belly button left behind at that site. Mm-hmm.
So for the people that have like innie or outie, does that matter for like how close they cut the cord? I've also heard that.
I don't know about that. I think what she asked about innie outie belly button. So there are some muscles that should. The best place to about this. So where the umbilical cord went in, there are muscles around that. And how close those muscles close up probably has something to do with whether it's a outie or an innie. But, I don't think how you cut the cord has anything to do with that. Because otherwise, people would be way more standardized in whether it's innie versus outie belly button. But I don't think it's cord cutting technique that affects that. So like Deja was asking about, there are many times when the fetus is not positioned in the best way. This is what you want, head down, face toward the mom's spine, and that's called anterior presentation. It's anterior presentation is the baby facing the mom's back. So to me, the name is kind of opposite of what you would think. This is what's best for safe delivery and for best fetal or infant outcomes. If they're head down and they are facing the mom's front, that's called posterior presentation. And this is less good and less safe. And women who are having labor with the fetus in posterior presentation, a lot of times that's called back labor. Like their back is facing your back, and that can lead to a longer and more difficult labor. It's a little bit more difficult to deliver a baby that is this way. The other thing that can happen is they are not face down, but they are feet down or butt down. And that's called breech positioning. If the fetus is head up and is breech, you at least hope that their feet are tucked up like this, which is complete breech. Sometimes they can have one foot coming down, which is not the best. You could push that back up. It's not pleasant. Or if they've got their feet up next to their head, that's called a frank breech. These terms, I don't need you guys to know, but just to know that breech is head up. And most of the time, if you are in standard US medical obstetrician care, they do not like to try to deliver breech births vaginally because there's more that could go wrong. And that affects their malpractice insurance and things like that. But there are doctors who are familiar with delivering breech babies vaginally. And probably the person I know that has done the most out of anybody is actually Professor Rudd's dad. So he's a obstetrician. He's retired now, but he did a lot of medical missions all around the world and delivered probably literal tons of babies over the years. Sometimes not in hospitals, sometimes in the field. He's done breech births, back labor, all of it in field conditions. But a lot of younger doctors will not try it, and they will recommend C-section.
Is it possible to get a C-section and have like a plastic surgeon in that same time?
Sort of, yes. That's a weird like insurance situation. And most people don't do that unless they've got really good insurance and can pay. You would end up paying the plastic surgery part. You should end up paying the plastic surgery part separate from the birth part. But I bet in really big cities, there are people who specialize in that. But when I had mine, my doctor is just a regular obstetrician, not a plastic surgeon, but she said, she did the last two, and she said that each time, like, she would slightly pull a little bit, sew a little bit extra, just to close up the extra. Yeah. It's easier to do it all at once. What else was I gonna say about this? So mostly, just to reiterate, posterior presentation is face forward, but still head down. Breech is head up. There's no special word for being head up. Well, there probably is, but I don't know it. Being head up and facing front. Oh, I know what I was gonna say. So there are two things. There are ways that people can try to turn the fetus if it's head up, but it's really not very easy. So once they get a certain size, trying to turn them in that available amount of space is difficult, but there are all kinds of things people try. There are doctors that will try to do what's called an external manipulation, try to make them turn. Doesn't always work. And the second thing I was going to mention is that before the modern medical era, a lot of the women that had worse outcomes during childbirth, it was because of these conditions. So sometimes having a C-section is going to be the best outcome for the mom and the fetus. A lot of women that used to die in childbirth, this may have been some of the reasons, not the only reasons, but the ability to do C-sections is a good thing. However, we'll go to this slide. So in the US, in current times, about 1 in 3 births is a cesarean section. That's way too high. Because having vaginal birth is usually best if there's not an immediate danger to the mom or to the fetus. So something else to note, once you have had one cesarean birth in the US, it is difficult to go back and having vaginal birth afterward. It's hard to find doctors that will do it. I have friends who have found doctors that will do it and they have good outcomes, but that's one reason why the C-section rate is so high, is that once a woman has had one, she's going to be assumed that the rest that she has will also be a cesarean section. In your grandmother's times, C-section births were done with a vertical incision like this. This is less good and it leads to less good outcomes for healing for the mom. And then this type of incision is more likely to have uterine rupture later. But these days, horizontal incision is more normal and they do these quite low. So it's normally just right above. Well, it's very low incision and not very noticeable, but the horizontal incision is better if you do have to have C-section. Well, assuming that the mom does have a vaginal birth, there usually is sufficient room in the pelvic opening for the fetus's head and shoulders to pass out. But basically, you're imagining, okay, the head is going through this space, and there are a lot of muscles in this area, and there is urethra, and there's a large amount of stretching that goes on there. Women talk about bouncing back. Bounce back from birth. This may or may not bounce back super quickly. And so one area of occupational and physical therapy is what's called pelvic floor therapy, to try to rebuild this muscle strength for women that need that. So all of this muscle and ligament structure here is called pelvic floor. And you want pelvic floor, if you were looking from a front view, to kind of be flat and not bulge down like this. So pelvic floor. Here's a brand new newborn, still attached to placenta. They formed the umbilical cord into a heart, which is kind of cute for the photo. He or she like really looks great. Like real chubby, real pink, healthy. And you can kind of see this white stuff on their butt. When they're born with this covering called vernix, and it kind of protects their skin. That white stuff is called vernix, and usually one of the first things that the nurses do after they assess their general health is they try to wipe that vernix off before they bring them out to you. And they bring them out in that little blue and pink and white stripy blanket. And normally they would not be still attached to the placenta at that time. I just really like this picture. So another aspect that can increase pregnancy and birth risk is where did the placenta form? So remember, wherever the blastocyst implants, that's where the placenta is going to form. And you hope that that's kind of up high in the uterus. That would be a good spot. Low implantation, you run the risk of the placenta covering up the cervix to some extent. So low implantation, you've got placenta is a little too close to the cervix. If the placenta is actually blocking part of the cervix, that's called placenta previa. And that could be partial or a total block. And in this case, you would not even want to try vaginal birth. That would be, no one should try that. We're often saying, this situation would need a C-section all the time. And with modern medical care, it's going to be known before birth where the placenta is. That would be known, and a C-section would be needed in that case. Fortunately, it's not super common that this happens, but it can happen. It's called placenta previa.
To find that out is through ultrasound.
That's when they would know. So when you do pregnancy ultrasound, the ultrasound tech is not the one that would tell you, but they're going to determine where the implantation is and how high it is or how low it is. And if it was kind of low, they would keep monitoring that more as the pregnancy progresses. And that's how it would be through ultrasound. Yeah. Mm-hmm.
So for people that are like more narrow hips,
Mm-hmm.
is that is that like a dilation thing where they're like, we recommend a C-section?
That's
like, what's the,
That's based on these measurements, which are bone measurements.
okay,
And
so like, is it that the baby might not fit through that?
there are some cases where it's possible the baby may not fit. Less than you would think. Because through development of modern humans, having really narrow birth canal would be maladaptive, like in an evolutionary sense, because if it was really narrow, you would not have living kids, and then that trait would not persist. So there are some women that would have literally too narrow of an opening through the bones, but not as much as you would think. What tends to literally happen is let labor happen, see how it's progressing. And then during the monitoring of labor, nurses and doctors are going to have a good sense of whether their head is literally stuck or if it's just taking a long time. It's not usually that their head cannot pass through the bones. And the other thing that helps with that is that the bones in babies' heads aren't fused. So they can literally like squish together and become cone-headed while they're being born. And then after, hopefully your bones will come back, spread back apart, so. Mm-hmm,
Question two, back to the, C-section.
mm-hmm.
I've heard that once you have a C-section, the rest of them, you have to have a C-section.
Most of the time. You have to try to find a doctor that will agree to let you try a vaginal birth. And they are few and far between. So I have a friend here that found a doctor, and there's basically like 2 in all of upper East Tennessee. And you have to, if you can find one, you have to travel to where they are. But a lot of doctors they don't want to do it because of their insurance, basically. It's not because they're not confident that they can do it. It's mostly a insurance and malpractice, and there is a slight risk of uterine rupture. So once you've got a cut, it's basically scar tissue there, and that would not act like the rest of the uterus and the stretching and the contracting and so on. So there is a small increased chance of uterine rupture. And the term for that is VBAC. So it stands for vaginal birth after cesarean, VBAC. Is that terminology? The other kind of crummy thing about having cesarean births is that you should not have an endless number of them. So I had 3. I think most doctors would say that it's okay to have 4, but after that, you really should. How many times you want to have a cut through your uterus? Not endless number of times, so. Yeah. That said, I tried really hard not to have a cesarean. So if it happens to you, it's okay. Move on. Don't beat yourself up about it. This slide, we're not going to go over. It's not that essential. So I want to use the rest of the time to kind of do some reviewing or looking at what the exam questions are like. So we'll go to the review sheet here. And this exam is kind of differently formatted than the rest that we have had. So the first page, it's a whole page list of different functions of reproductive anatomy, and you're gonna have that front back diagram with the letters labeled, and you pick out which letter goes with that thing. And that's about 1/4 of the test, actually. So it's not to name, oh, this is the vas deferens. It's not to name it, it's to match. This is matching what it does. Another big question that is on there is the timing or the timeline. So on the test, there are about, I don't know, 8 or 10 things that I want you to put them in order on a timeline. It's not so much to say exactly when does that happen, but what is the order of these? So there's a question about that. And the timeline that we had drawn up in class, that ought to have all the things I'm asking on it. Then there is I'll go to this next. There's a matching. So a big matching question, and the stuff that's in the matching is going to be like placenta previa. Did I just say that right? Placenta previa. It'll be spelled right in the matching. Stuff like breech, stuff like preeclampsia, that type of thing. We don't have mitosis and meiosis. You can just take that off. I don't usually fit that in.
That is crazy. I'm so glad it's not in the.
Well, I don't know. I choose to do more pregnancy and fetal development stuff instead of that, because you'll get that in other classes if you need it. So what's left on this is the contraception section, okay, so that, your chart of the contraceptive methods and their failure rates and stuff, that'll help you study for that. So I want you to know, what are they classified as? Is it a behavioral way? Is it a hormonal way? Is it a barrier? Or is it surgery? And make a note. Copper IUD is more of a barrier. Hormonal IUD is a hormonal method. So IUDs, it depends on what kind they are as to how you classify them. So there's a list of methods, and you write out to the side of it, what's the category that this fits in? And then the next part is to know, okay, of those methods, which ones are high failure, low failure, or medium failure? And this year we are using typical use rates. So we're going to use typical use rates. And I think we had said less than 5% was low. Greater than 15% is high. And then if it's something in between there, it would be medium. And then for each method, like what's good about it and what's bad about it. Pros and cons.
That one, are we gonna be using the table?
The particular method, there are things on that table that I think aren't in the list that we talked about. So on this list, spermicides, I did not really talk about that as a standalone method because it's just not great. Not many people use that anyway. And I think for sponge, on that one, just go with nulliparous, like assuming that the woman has not had a birth before. The others we did. Did I answer your question? Sometimes I will I say something and I'm like, I don't know if I actually answered the question that you actually asked. So I know what I was gonna say. So to kind of make your list of the methods, use the slides first and then match it to what's on the chart. That's what I was gonna say. So we had talked about fertility awareness, and on that chart, that's what they call rhythm, symptothermal, 2-day. There's a group of those that falls into that. Withdrawal method, we had that as a method, and that one shows up a couple places on that chart. Then we had the barriers, which are basically condoms, diaphragm, sponge, and then copper IUD would be also a barrier method. Hormonal, we had a lot of those, and those are on the chart. You'll just want to make sure you're kind of matching the name. If you have a question during the test, like if I put on there Depo-Provera, you could come up and ask me and I would say like, that's an injection. That's a shot. So the names pretty much match up with with what's on the chart. But if you're not sure, like if I'm using a brand name, come up and ask me during the test if you have a question. Pills are hormonal. Marina IUD is hormonal. And then we had vasectomy and tubal ligation as the surgical methods. Plan B, this is a hormonal method. I would count this as hormonal. This drug is not a contraceptive method. This is a definite abortion method. So that's not going to be in your list of methods. Good to know the name of it. It'd probably be a matching, but it's not a contraceptive method. This one we classify as a hormonal method. It's my Nana. We went to see her at Thanksgiving. Yeah, so we're done some early. Do you have questions about stuff you want to review? Maybe not. If you've got questions between now and Wednesday on the test, let me know, but, test Wednesday. It has some multiple choice, maybe. It's less than 10 if it has less than 10, yeah. Because these other questions have a lot of points with them, so. Not as many multiple choice as usual. There's no lab this week.
You know, I walked past where they can tell me, you know, when to go at 8 o'clock in the morning. Come over.
Yeah, if you want to go to open lab for AP1, that's available, but